In respect of time schedule, I begin straightforward. A 79-year-old female patient, BMI 31.2. The transthoracic echo, severe aortic stenosis with a Vmax of 4.3 meter per second. Gradient for 75 peak and 46 mean millimeters of mercury. LV ejection fraction 45 to 50%, RVSP 40 millimeters of mercury, and mild MR. Coronaries with borderline 60 to 70% proximal stenosis in a relatively small RCA. Medical history, diabetes, hypertension, mild CRF, history of NSVTs on medical therapy, hypothyroidism. We see the medication of the patient with diuretics, among others, Euroscore to 3.39%, STS mortality score 3.81%, and STS mortality morbidity 11.3%. The transthoracic parasternal long axis view, we see the heavily calcified aortic valve with no relevant regurgitation. The X-ray of the patient and now the ECG with the known LBBB and sinus rhythm. We see the heavily calcified valve, 25 millimeters at the area of 4 millimeters above the annulus, the diameter. We see the relative low height of the left main. We have an area of 5.19 square centimeters, the diameters of the annulus 23 to 27 maximum. With an LVOT a bit bigger with an area of 6.08 square centimeters. Here we see our measurements, the CT. We see the calcification, and we have a measurement of 24 millimeters from the left main to the calcification. Again, the height of the left main relative to the annulus, it is really low.
Kyriakos, sorry to interrupt you. Can you hear me?
Yes. Yes.
Just to clarify that the video that all the audience can see on the top of the screen is from this procedure. So it's edited, and you can watch everything from the beginning to the end. So this is the ProgLite insertion. So just to clarify this. Okay, you can carry on.
Thank you, Dr. Spargias. We see the heavily calcified valve and the coronaries. The peripheral access seems not to be a problem in the CT TAVI. We see the right side, the angiography, and the left side. The aortography of the patient, we'll proceed. Here we have the balloon expansion, a 23 millimeter balloon of Edwards under rapid pacing.
So Kyriakos, let's make a stop here. This is the format of the TAVI rounds, and let's go back to make a short discussion about any concerns that you would have for this case. Let's go back to the CT scan screening, if you would. More back. The beginning of the CT screening. Okay, so here we see that the annulus is 81, 82 perimeter, and 519 millimeters is the area. The LVOT is a little larger, so the LVOT is opening, not closing. And if you go to the next slide, here you see that this is a bicuspid anatomy. You see a raphe between the left and the right sinus of Valsalva, and you see calcium a big bulky calcium at the base of the non-coronary sinus leaflet. And this calcium would certainly affect and influence the expansion of the deployment of the valve. That's why we did these measurements here. So we measure from that calcium to the other side, and I think this comes to 24 or 27, depending at what height you are going to measure it. So if you measure it, the worst scenario is that if that calcium stands firm and pushes the valve completely on the other way, then we have 24 millimeters. Is that right?
Yes.
So we can also discuss about it, maybe with the audience and the moderators. As you see, this is a bicuspid anatomy. And what are the other requirements for the measurements for bicuspid anatomy, both for selecting the balloon expandable valve or self-expandable valve?
Yeah, I think this is a very big discussion, Theo, that you can have. I just wanted to point out this fact on the CT scan screening, because this is the only thing that came out to my attention, that bicuspid anatomy, but the raphe is not calcified. It's a clean raphe. Most of the calcium is on the non-coronary leaflet. So this measurement comes it's a little borderline and bothering to have just 24 millimeters there. And then if you go to the valvuloplasty, balloon valvuloplasty with autography, and you also saw that the level of the left main was low. It was just 8 millimeters, so it is a low left main. And here, this is a 23 minus, I believe, balloon, so it's probably a 22 balloon. And you see how the leaflet behaves in relation to the left main. So I think it follows the expectation that it will move towards the left main because most of the calcium is on the other side.
Yeah.
And if you say that this is a 22 millimeter balloon, then it goes very close, the white line of the leaflet in front of the left main, it goes very close. So if you go to put a 26 millimeter balloon expandable valve, because the sizing is for the 26, so probably there will be a problem there, because you will need another 4 millimeters, and I think that 4 millimeters would probably create a problem there in coronary obstruction. If you're going to use a self-expandable valve, depending on what device you're going to use, you know that the 24 will be very, very borderline, which is like the waist of the evolute will be 24. But if you don't put it exactly the waist in front of the left main and go a little bit higher, then probably the waist will be more than 24 and you'll have the same problem. So I just wanted to point out this peculiarity of this case, and then I will leave you to continue the discussion between you guys.
Yes, this is the most important afraid situation, that huge calcium on the non-coronary sinus and the low-lying coronary osteo. Even the Valsalva sinus is high. I mean, there is no shallow sinus of Valsalva, but you clearly demonstrated that with the balloon and with the angiography at the same time, that the calcification pushed the balloon and there's risk of coronary obstruction in both valves, I mean. But for this, yes, please.
I think this is a nice illustration of balloon aortic valvuloplasty indication during TAVI. Many cases are done with direct TAVR, but especially bicuspid valves, we frequently do BAV for sizing, as well as, in this case, to monitor what happens with the left main.
Did you make supraannular measurements in this case?
I can can see if we have some.
Yes,
Yes.
we have that. We have that measurements back in the CT scan, but because there is no calcium in the raphe, although this is a bicuspid anatomy, I wouldn't expect it to behave like bicuspid because there's no calcium, as you can see in the raphe. All the calcium is on the non-coronary, so the raphe would give away. And this is what happens and what we see when we do the valvuloplasty. The raphe is not calcified, it gives away, and the valve moves all that way. And so here is the 4 millimeters above the annulus. You see the diameter commissure to commissure is 25 millimeters, and you can see the design exit opening of the bicuspid valve.
May I?
Please.
So this is very unusual in native anatomy to have a problem of coronary obstruction, threatening coronary obstruction. It's extremely rare. And I think if that was, it's just the distribution of the calcium that makes this high risk because everything is on the other side of the left main. That's why it pushes the valve. It will push any kind of valve towards the left main. So it's not that the sinus of Valsalva are not wide enough. It's just the distribution of calcium, which shows how important it is to take into account in your screening, in your planning, of every little detail. So like you said, if you think that this is a bicuspid anatomy, you say, okay, it will push me away because it's bicuspid. But no, it's not like any other bicuspid. It's a bicuspid without calcium in the raphe. So that's why it behaves this way.
May I add something?
Yeah, of course, Dr. Zacharelis.
It looks like a rather challenging case, although keeping in mind that this is a bicuspid anatomy, you have all the favorable assets of completing the procedure safely and successfully, mainly because the calcification pattern is not that bad and you have all the good signs for you there. But I would be rather worried about the left main. And I couldn't agree more with what Mike said, that it's very important to do the balloon valvuloplasty before you get a lot of information. From what I saw there, I would be more assured to go ahead, but keep in mind that I might need to do some coronary protection.
So for those who are watching the video, you will see that this is exactly where at this stage now, the valve is there, but we also have coronary protection. You can see the manifold there. So if Kyriakos, this is the initial coronary angiography. So there was no significant coronary artery disease. Here we have the wire for the protection. We're expecting potential problem here. This is the 26 Resilia valve that we haven't talked a lot about it, but I'm sure you will. And then we have the stent position exactly at where we believe we need to implant it in case we have an obstruction of the left main. So at the last moment we do this coronary wiring, and we advance the stent at the very last moment when the valve is there. So we don't want to have wires and stents for a long time in the coronaries, especially in the left main. So we advance the wire at the beginning, just the wire. We pull the guide catheter back, so it's not into the left main. And then when the valve crosses the annulus, then we advance the stent like we're doing here to make our final positioning.
And there's no pigtail in the non-coronary sinus also? Yeah.
Correct,
Yeah.
correct. We found out that with the balloon expandable valves, in all cases, we need to do coronary protection. It doesn't matter if we have another valve, like surgical or TAVI valve for landmark. We can use the guide catheter like the JL4 here, because this guide catheter has large lumens. So just with manual injection, as you can see here, you can have a very nice aortogram to guide you for the valve implantation. So there is no need for third aortic access.
It's a great demonstration.
So here we see our stent, Onyx 3.5, 18 millimeters in position, and the Edwards S3 Resilia 26 millimeter -2 valve. And we see under rapid pacing the valve implantation. We see the struts of the valve touching our stent. The patient was stable all the time. We see the great need for the stent implantation.
So what do you think about this imaging we have immediately after implantation of the valve?
Actually, I want to ask to the panel and the audience, will you put the stent proximally or distally for the protection of the coronary ostium? Dr. Reardon?
What I'm worried about is if you decide you don't need the stent, you have no telescope in there, you can strip that stent off and pull it out. So if I do this, I'd have a telescope down there, my stent inside the telescope. Then if I decide I'm not going to stent it, I can pull it out. It doesn't look to me like you're going to need to stent this. You don't want to leave a stent in the left vein if you don't need a left vein. So a naked stent, to me, is the worst thing unless you're absolutely sure you're going to plant it. And planting a stent in the left vein you don't need it is not a good thing. So I'm worried about, I always worry about stripping these stents off unless it's protected by telescope or guideline or something. But I'm not a cardiologist.
Maybe distal,
I feel distal placement is, especially in this case, would be a little bit safer. Now, with regards to what Dr. Spargias asked, I would like to see another image with the parallax off. But for sure, there is you can see there is a chunk of calcium right underneath the ostium of the left vein. So I don't know if there is another image, so we could assess a little bit better what we can have, what we have.
Sorry.
There must be another one. Next one.
There are two images.
Yeah. So let's see the parallax, the next one.
This is the next one.
Okay, so these are two 90 degrees difference imaging, and you can see the white line of the leaflet going up to the STJ. And I think the only thing that keeps the flow is the stent, and the power, the straightening power of the stent in the wire that pushes the leaflet, the native leaflet, down. And this allows for this flow we can see here. I think that your discussion was where to like park the stent before the implantation if you need to be distally into the LAD. Was that the discussion, the earlier discussion?
Yes, the discussion was before the protection. We put should we put the stent parked distal or proximal?
Oh. Yes, that was a discussion that I had many times, but there are cases that when you pack the stent into the LAD, if you have a big stenosis, especially if you have other hardware there, like a bioprosthetic valve, and you put another valve, the stent may be caught, and it may get off the balloon. There are cases that this has been reported. And so that's why I think the best approach is to have your stent at exactly the area you want to implant it. Of course, there is the risk when you implant the valve, the balloon may touch the stent and move it slightly out of the exact position you should have it. But I also accept this movement, this interaction between the valve and the stent as an indication that stenting is needed, because if it reaches to the stent and makes this bend to the stent, like we've seen in the implantation here, I think this is the sign that the valve reaches the STJ and it will create a problem in the coronary flow afterwards.
Please. There's a question from the audience.
Kostas, congratulations for the case. Just I'm wondering if it was better to have a guide liner, a protection of the stent with a guide liner to avoid the interaction between the valve and the stent. So you have the ability to move forward or backward to assess the better position of the stent.
You're absolutely right. We've just tried to keep the procedures as simple as possible, Manoli, by avoiding to have a lot of hardware inside. So we have used guide liners a few times, but here, because the anatomy was large, there was still a hope that we wouldn't have this problem and we would avoid the final standing. It's true, if you have a guide liner, you can have your stent completely into the catheters, but I think it adds some complexity, and we try to avoid that.
And how was the hemodynamic status of the patient when you put the valve?
It was good. We had no signs. It was light sedation. We had no sign that something was going wrong. Blood pressure was stable, ECG was stable. But the impression was that here we will have a real problem if we remove the stent. And then we might have the difficulty to advance it again. This is something that has been reported many times. And we weren't so lucky like the case Dr. Zyaka saw yesterday, that they removed the stent and then they re-advanced it when they did the reassessment, and it was easy to re-advance. In some other cases, when it's very tight, the space is very tight, you cannot re-advance. So you have to make a decision now. If you remove it, then you may have difficulty to re-advance it again because it will be metal to metal. And I think the decision here was very clear to us that we should deploy the stent. And you can see with this autography with the guide catheter that, of course, the position of the valve is very nice. It's like 80, 20%. We have no regurgitation.
Also, seeing the impaired flow, maybe retrospectively in this occasion, a guide liner maybe would affect also the flow for some instances in the left main.
Correct. It would occupy more space. You're right, Katsianos.
So we're going forward. Here we see the stent implantation, Onyx 3.5, 18 millimeters. And this is post-implantation.
And here you see how the white line of the leaflet is pushed downwards. So it doesn't reach to the STJ. I think it's pretty clear here.
Over different angles.
And in this angle, calcification go a little bit forward. Very interesting. Yeah.
Here.
This is the flare. You see that the stent is compressed. You see that there?
Yes, I mean that stent is compressed.
And we did multiple post-inflations to flare the entrance of the stent. And can we move on?
And here we see our final orthography, a good outcome.
So congratulations, and this is a very educational case, and the valve position is very good, but it's very, very important to put the protective guide wire and stent in this very important case. Dr. Chrissohris, yes.
Congratulations, Kostas, and to all of your team. I think it was a wonderful performance. One quick question. There is some reports in the literature that say that, when you're finishing with stent in the left main and going sideways with your valve frame, you should finish with a kissing balloon in the valve and the stent. Are you an advocate for that, or you think that's not that important?
I think it's an unequal cross of forces, because on one hand you had a stainless steel frame with a thickness of 1 millimeter, and on the other side you have a coronary stent with a thickness of, just a fraction of the millimeter. So I don't think this fight is equal, and if you do a kissing, I don't think it will affect anything. I think you should make sure that you expand very well your stent. If need be, take a non-compliant balloon, larger size balloon, to make sure that it's well expanded. I'm not saying that this is a perfect solution, this way of coronary protection. It gets you away with a good result of the acute procedure, but in the long term, it's not certain that this approach will be without problems. So imagine that you have to go back. This patient had good coronary arteries, but imagine that there is coronary artery disease, or this patient comes back with a problem in the anterior coronary system. I think it will be very, very difficult to cross this stent correctly through its true lumen and approach the coronaries. So it will be very challenging if there is any need in the future to access these coronaries. That's why when we do this coronary protection, we shouldn't deploy the stent if we're not reasonably sure that we need to do it. It's necessary to do it, because if we do it lightheartedly in all cases, we may have problems in the future.
Okay.
Okay. Well done. Congratulations.